This is Audible Bleeding, the Vascular Surgery Podcast. We're here to help you keep your finger on the pulse. Well, welcome back to Audible Bleeding. I'm Adam Johnson, and we are delighted to have Dr. Peter Lawrence, the Senior Editor of the Journal of Vascular Surgery, back on Audible Bleeding to discuss the August issue's Editor's Choice. The Journal for Vascular Surgery has made these articles free of charge to download for the month of August. So we'll have the links to the YouTube video where Dr. Lawrence summarizes these papers and also links to each of these papers in our show notes. But today what we're going to do is give a little bit of a behind the scenes to this program. And we're going to ask Dr. Lawrence some questions about how they chose these papers, how they contribute to the literature, and give you some insight into the background. So thanks for joining us today, Dr. Lawrence.
Well, it's a pleasure to return and to talk about something that's not only very important to those who are editors and on the editorial board, but to all people who manage vascular diseases.
And so this is our first episode where we're covering the editor's choice for the JVS. So I thought we'd start with a few general questions about the editor's choice program. So what's the goal of this program and how it complements the issues published in the JVS?
Well, as you probably know, this started several years ago, about 3 years ago, when Peter Glavitsky and he became the editor-in-chief and I became the senior editor. And we were interested in ways to both expand the influence of the journal, but also make it attractive to people of different generations and to keep up with the trends in publishing, which we're using a lot more social media. So there are ways that we've done that through these videos in YouTube, but also other ways that we've used social media to attract interest in the journal. And the main issue is that we believe it's a great journal, and we want to highlight very important papers, but also attract interest to the entire journal. So we try to pick papers that will attract an interest and be appealing and show people how good the Journal of Vascular Surgery is.
Well, fantastic. So what's a little bit of the process for how these articles are selected and then how you make them available?
Well, the articles, as you know, there are a number of submissions, and depending on what country you come from, United States is obviously an important country and the largest, but actually more than 50% of the papers come from outside the United States. So we receive a large number of papers, and they go through a very detailed review process. Dr. Glavitsky and I see every paper at the end and most papers at the beginning, and then they're assigned to associate editors, and they then not only read the paper, but assign them to reviewers. It's usually one on the editorial board and at least two or three that are not on the editorial board. So they've gone through an extensive process, and they get graded by each of the reviewers and each of the associate editors. So one of the first things we do in deciding on the papers that should be highlighted through a video is the papers that have some of the highest rankings, but that's not the only factor. We also are interested in the audience, and for our audience, which is vascular disease specialists, the majority are vascular surgeons, but there are a number of other specialties, they want to hear about papers that are important to their specialty. So the importance of the topic, the originality of the topic, the quality of the paper, what the evidence is, how big it is, how many patients are involved, whether the methods are very sound, and then how it's presented as far as tables and illustrations, graphs, often a life table, and then overall sort of what's the impact of this paper on disease management. And then the last thing that we do is we always try to have a distribution of types of papers. So we wouldn't want to have 4 papers on aneurysms. We might want to have one on cerebral vascular disease, one on aneurysm, one on lower extremity revascularization, and then one on education, for example. So it's a combination of many factors that enter into how those 4 papers are selected for the video.
So we have 4 papers today that we're going to discuss. Each one is fantastic and very different. So I thought we could just dive right into that. So Again, we don't have any ways to display the tables or the figures, so I encourage you to click the link and watch the YouTube video or go and just download these articles directly for more specifics. But we'll kind of dive into these papers now. So the first paper you discussed in your video and then we'll discuss today is titled Statin Use Improves Limb Salvage After Intervention for Peripheral Artery Disease. This is a paper by Dr. Gaurav Parmar and colleagues from the University of Alabama, Birmingham. That's a single institution retrospective review of 488 patients with peripheral arterial disease who underwent surgical or endovascular intervention between 2009 and 2010. They found that about 41% of the patients were on appropriate statin therapy, and although these patients had higher rates of comorbidities, they actually had increased survival and limb salvage at 5 years. So this is a really interesting single institution retrospective review. But Dr. Lawrence, why specifically did you pick this article?
Well, there's several reasons. I think, first of all, we recognize as vascular surgeons that we're not only responsible for doing endovascular open procedures, but also maximizing the likelihood of both a short and long-term survival. And therefore, we're responsible for either putting patients on appropriate medication, or if we don't do it, making sure that a primary care or other specialist does. And I think the reason that this paper is unique is because, first of all, we recognize that there is not going to be a prospective randomized trial of statins for any of the vascular diseases that we take care of. The reason for that is because there have been well-established prospective randomized trials that have shown that the survival is higher for patients with cardiovascular disease that are placed on statins. So it wouldn't be ethical at this point to put half the patients on statins and half the patients not on statins, because you would increase the mortality of patients, but it's usually myocardial infarction and stroke. So what was unique about this paper was that they looked specifically at limb salvage, not being able to do a prospective randomized study, but never ethically being able to do that. And they found about three things that I thought were critical. And one was that more than half the patients are not on statins in spite of the fact that we know that they should be. So that's a really important message. And then the other one was that there are many well-established beneficial effects in this paper of putting patients on a statin, that they actually do better, not only as far as their cardiac, their heart risk, but also their PAD risk. So survival, limb loss, and indirectly that measures graft patency. So all of those things were good. And even though it's a single institution, I think it addressed a very important topic and told surgeons we ought to get our act together and make sure that patients who we operate on to get the best results, that they're placed on statins.
That's great. Yeah, I almost think that they should just put statins in the water here. It's so good for patients. But how do you think that this paper should affect the reader's clinical practice?
Well, I think that all of our patients should have some clinical relevance. In this case, to me, it would be that you go back and look at your own institution and your own practice and either develop a system for you to put patients on. I don't know if you noticed in here, but they said they started with 20 milligrams of simvastatin, then increased it over a period of time, particularly for high-risk patients, up to 60 or 80 milligrams. But you want to have a system of both getting your patients on statins or making sure that someone else does. So compliance is one of the critical, I think, messages of this, is either do it yourself or have someone else do it. And not only will the patients do better, but your patency and your success will be higher. And that is one of the measures of quality for us as vascular disease specialists.
Do you have any thoughts on why maybe the statin use is low right now and there isn't as good compliance with the guidelines?
Well, I think that there is not a single specialty that manages patients with PAD. And many of these patients were not on statins when they saw whoever was taking care of it at the University of Alabama. I'm not sure of all the specialties, but many of the patients were not on statins to start out with, and they may have had a more acute type of problem. So if somebody comes in with, ischemic breast pain or gangrene, they may be admitted and treated. And I think part of it is that they have not been identified as patients with PAD before they're treated. I think the other is that they probably did not have a discharge system to make sure that all patients got on statins.
Thanks for that. And I think everyone should definitely go back and read this paper. And I think it definitely reinforces the guidelines that patients with PAD really should be on appropriate statin therapies. We'll jump to our next paper. This one is titled The Technical Aspects and 30-Day Outcomes of the Prospective Early Feasibility Study of the Gore Excluder Thoracoabdominal Branched Endoprosthesis, TAMBI, to treat pararenal and extent for thoracoabdominal aortic aneurysms. This is a paper from Dr. Gustavo Oderich and colleagues, and the title pretty much explains it all. It's a multi-institutional prospective, non-randomized, early feasibility, industry-sponsored clinical trial. It includes 13 patients with aneurysms who were not candidates for endovascular repair with commercially available endografts due to either insufficient proximal landing zone or involvement of the mesenteric arteries. And these are patients treated with the Gore Excluder TAMBI between the years of 2014 and 2016. They outlined in detail their technique for deployment and confirmed early feasibility with high technical success, no mortalities, and low morbidity in this early experience. So I want to just point our listeners that we had Dr. Oderich on our podcast about episode 7. He talked just briefly about this trial, and we highly recommend some listeners go back to hear Dr. Oderich discuss branched and fenestrated devices for complex aortic aneurysm. So I'll turn it over to Dr. Lawrence. So what specifically about this paper excited you and made you choose it for the editor's choice?
Well, there's several things. First of all, I think most surgeons in the United States recognize that sometimes the process of approval for new devices in the United States is so long that many of the newest devices are developed outside of the United States. So this was an example, and as I understand it, that there was an agreement with the FDA to do an early phase study with a small number of patients as sort of a feasibility study. So I think it's showing a awareness by the FDA that the investigational device process, in order to keep new devices being developed in the United States, needs to have this rapid reporting of early phases. The second thing is, even though they're a very small number of patients, they're by extremely distinguished people who are well known in the field for their expertise in endo. The third is, as always happens in Mayo Clinic papers, is the illustrations I think are just spectacular. You know, you look through the two approaches from the neck versus the iliac arteries, and you realize for the branches, and you realize the different options, and you can really understand the procedure with the illustrations. And then the fact that they had such good results, the outcomes were remarkably good, and I assume will lead to further studies on larger numbers of patients. But it's just the fact that this is something on the cutting edge for a problem that all vascular surgeons who deal with complex aneurysms and pararenal and the thoracoabdominal extent 4 aneurysms, that this is the last frontier in aneurysm in the abdominal aorta. And I think that this is one of the many devices that will help to address the best management of these patients.
Yeah, I was really impressed by the detail that they went into with how to deploy the devices. And yeah, I would definitely encourage the listeners to download this article or to watch the YouTube video to see the images, because it definitely goes through, you know, how the best of the best use a complicated device like this. So what are the next steps for a device like this, just to put this paper in context?
So there are two things that have to be done. First of all, there has to be a larger study because this is really a feasibility study. And although they talk about complications and had very few, it has to be expanded to a larger number of patients in possibly a larger number of institutions to make sure that it's translatable. And then finally, it has to get out into the public, into the non-highly specialized institutions that have special expertise, to see whether people who don't have that unique expertise can achieve the same results. So it will be a process of expanding the study with larger number of patients, more institutions, and also longer range follow-up. This is only 30 days. And as you know, things like endo leaks can occur later. And there are several devices that had great early results without endo leak that had a type 1 or a type 3 endo leak that became very common at 6 months or a year or 2 years. So I think that long-term results are also necessary as this device is getting introduced as an option for patients with the pararenal or juxtarenal aneurysm.
Great. I look forward to reading more about this device and similar devices in the JVS. So we'll jump to the third paper. This is a paper titled Validation of a Preoperative Predictive Model for Mortality Within 1 Year After Endovascular Aortic Aneurysm Repair of Intact Aneurysms. This is a paper from Dan Neal and colleagues from the Society for Vascular Surgery Patient Safety Organization Vascular Quality Initiative based out of Chicago. It's a registry-based retrospective analysis of 20,336 patients who underwent endovascular repair for intact abdominal aortic aneurysms between 2011 and 2015 to develop and validate a regression-based predictive score for 1 year mortality. They developed a simple score based on 10 preoperative patient factors with good prediction with an area under the curve of 0.759 in both the development and the validation cohort, and a sensitivity of 70% and specificity of 70%. This score is also available through the QXMD app, along with a number of other risk scores that have been derived from the VQI dataset and published in the JVS. So, Dr. Lawrence, how should surgeons kind of use this score?
Well, I think that what was interesting about this paper was that these authors addressed a very common problem for those who treat aneurysms, which is sitting down with a patient and who often has no symptoms and only is told that they have an aneurysm, and they usually don't even know they've had it, or it's been picked up by cross-sectional imaging, by CT or MR or some other reason. And they're told they have an aneurysm and it needs to be fixed. And we as physicians and they as patients want to know what the likelihood is that if they don't have it fixed, that they'll have a complication or a problem or die from it. And what's the risk if they do have it fixed? What's the risk? And so what this does is it goes beyond the typical surgical statistics at 30 days, which is how we traditionally have modeled our, prediction for patients. And it goes to 1 year, and it's saying to people, if you have an aneurysm, first of all, that we can tell and grade your risk based on a whole bunch of comorbidities, which went from 31 down to a much smaller number. And that if we take these 5 or 6 things and we grade them as to the degree of severity, that we can give you a much more accurate prediction of your survival from the procedure. I think what was also impressive to me was that there were a significant number of patients who had a significant risk, and yet they had aneurysms fixed which were below the threshold that most of us would say were part of treatment guidelines. So not only were the aneurysms smaller than most people would say they should be treated, but they were doing it in higher risk patients. And so those are the people where a change in approach by knowing this information could result in many fewer deaths or complications and better outcomes.
Yeah, and it seems that, a few of the factors, their body mass index, whether they're on a statin or beta blocker, these are sometimes modifiable. So, in theory, you could even calculate this, if you decide not to move forward with the surgery and just survey a patient, calculate it again later if it comes up or their risk factors change.
Yeah, I think that that's true. And I was interested in, I didn't actually review this paper other than when I did the video, but this concept of bootstrapping, where you take a whole bunch of preoperative candidates as predictors, and then you gradually drop them out and see if it improves the model. The area under the curve was 0.72. So those who aren't familiar with that, if it's 1.0, so this is 70% of that, 1.0, it's perfect. And if it's 0.5, it's worthless. So this is basically gives you the message that it's not perfect, it's pretty good, but also that you've got to take this in the context of looking at your patient and sort of giving them the eyeball test or the frailty test as well, because it's not worthless, but it's also not perfect.
Yeah, and these scores seem to work best at the margins. So it's great that they divided it into low risk, medium risk, and high risk, because it actually performs better when you're talking about the high risk and the low risk patient. But then the medium risk, you can be in that range where you can maybe go either way based on the clinician and patient preference.
I also think that figure number 3, which gives the odds ratios, you see 3 things at 1 year that decrease the risk of death. And those are the hemoglobin, which is probably less significant, but having, again, back to our other a preoperative statin decreases the 1 year risk. And if you have an ejection fraction, which is over 50%. And on the other side, what increases the risk, you can see so many factors there that do increase the risk. So just by looking at that and looking at your patient, it should help you in working with them to predict whether they should have their aneurysm fixed, and particularly if it's a small aneurysm, whether they should have it fixed.
I highly encourage everyone to read the article, watch the YouTube video, and then also, if you aren't good at math, you can just download the QXMD app, and it has this risk score in there so that you can use it right at the bedside. We'll jump now to the 4th paper and our final one to discuss, and this is titled "The State of Complex Endovascular Abdominal Aortic Aneurysm Repairs in the Vascular Quality Initiative." This is a paper by Dr. Thomas O'Donnell and colleagues from the Beth Israel Deaconess Medical Center in Boston, Massachusetts, along with a number of institutions that contributed. It's, again, a registry-based retrospective analysis of 1,396 patients with paravisceral abdominal aneurysms who underwent either fenestrated endovascular aneurysm repair, or FEVAR, chimney snorkel repairs, or physician-modified endograft repairs between 2014 and 2018. They found that the majority of repairs utilized off-the-shelf fenestrated endografts, which is increasing in utilization, but still about 20% of the patients in this cohort underwent repair with physician-modified grafts, and 20% used chimney or snorkel techniques. They found morbidity and mortality outcomes to be essentially the same between the groups, but they did find a higher rate of stroke and some morbidities in patients who underwent chimney and snorkel repair. So, Dr. Lawrence, this is a complicated paper, but what do you think is the major takeaway for this article for the readers?
Well, I think that the difference between this and Dr. Oderich's paper is this is real world data. So this is how it actually happens. It's not perfect because obviously not everybody belongs to VQI, but it is a real world. These aren't research centers that have people who are super skilled. It's anybody who participates in VQI and does complex endovascular aortic aneurysm repair. And they define that by the location of the aneurysms, again, in this sort of last frontier for abdominal aorta, from the celiac to the lower renals. And I think that the message to me is that particularly for patients who are better candidates for snorkel, in other words, where the branch to the renals goes outside of the endograft, whether it's a chimney or a snorkel, that long-term results may not be as good. And they point out that patients are highly selected. They're from different institutions. And it may not be that the snorkels are any worse, or the chimneys are any worse. But they did show that when you come from the neck and putting the catheters in, that there's a higher stroke rate, and that it takes a longer time to do it, and possibly because they're more complex patients, and a slightly higher mortality. I think there's also always concerns about snorkels and chimneys as to whether or not they're going to get an endo leak along that snorkel, which is sitting outside of the endograft. So I think this raises concerns about snorkels and chimneys, and it also tells you in real world data that the results are pretty good, but that complex endovascular can be repaired, and that there are 3 effective ways of doing it. And they're not identical, but they're pretty close as far as their outcome.
So do you think that the snorkel technique will decrease as maybe surgeons have more access to off-the-shelf or industry-developed fenestrated or branched devices?
I think that snorkel may be a temporary solution until branched and fenestrated endografts become used in virtually everything, but they're a bailout. And I think for some people who are very skilled with them, that they can get, if not the same, almost the same results. So there are sort of believers in snorkels and chimneys and use them all the time. And there are those who would say they would never use it. And then there's a group that use it selectively for bailout. And the question is, in this study, not knowing the philosophy of the different institutions, it may be that the snorkel and chimney is a little bit higher as far as complications, stroke, et cetera, because it's being used as a bailout when they didn't feel that they either had access to or could do a fenestrated or branched endograft.
Just one last question. So these last two papers have utilized data from the VQI, the Vascular Quality Initiative. I don't know if you could just kind of explain for our readers who may not be as familiar with the VQI. I'm sure many are, but for those that aren't, which institutions participate in the VQI and what the goal of that program, and then how you feature it in the JVS.
Well, I think that the value of the VQI is that it is prospective data where the data is entered after a very thoughtful and innovative approach is used to figure out what the different data points are that need to be entered into a prospective study for our most common vascular diseases. There are 11 modules, and there are a few more on the arterial than the venous side, but it includes cerebrovascular, it includes TVAR, EVAR, lower extremity, endo, open. So the common procedures that are done in vascular surgery have data entries prospectively. And one of the things that's unique about it is about a little over, I believe it's slightly over half of the patients are managed by non-vascular surgeons. So it's really the complete distribution of specialties that manage vascular diseases. And then the VQI gives reports on the outcomes, and you can have it as an individual, as an institution, or as a region of the United States. And now I think there are over 500,000 patients have been entered in all these 11 modules so that you can get very robust data that's real world data of doctors who are not involved in clinical trials but are taking care of patients. You can get real world data on outcomes, and it allows you to benchmark yourself. So let's say if you're dealing with an EVAR for an aneurysm, you can not only get your results and your morbidity and mortality in the areas where the data has been collected on your patients, but you can also benchmark yourself in your own institution, in your region, and also nationally. So it's been the source of a huge number of great patients. And we would consider it, since it's multi-institutional, large numbers of patients and real-world data, we consider it to be very valuable data. And that's why there's so many VQI papers that are published.
Fantastic. And Dr. Lawrence, thank you so much again for being on the podcast and discussing these wonderful papers. Any last words for our audience today?
No, just congratulations to those of you who have been involved in putting together. We're very excited about a collaboration, but also about the Audible Bleeding and what you're contributing to knowledge about vascular disease. And I think you're attracting a different audience than the journal does. And so we're thrilled that you're working and including us in your project.
We are Audible Bleeding, the vascular surgery podcast. Our team is committed to providing free, high-quality, unbiased content to our listeners. We currently do not take any funding from industry sponsors or advertising, and we hope to keep it that way. So if you want to help us keep bringing you great content, go to audiblebleeding.com/support and find out how. We'll put a link in our show notes.